Thank you all. My name is Leah Wapner. I am the General Secretary of the Israeli Medical Association. The Israeli Medical Association combines and embodies all the physicians in Israel. It is a voluntary membership, but we have close to 95% of the physicians are part of the Israeli Medical Association. We are quite unique because we have several tasks. We have some tasks by law. We are responsible for the specialty programs. We also have a very active role in the ethics of physicians. So we have a public role, and we also serve as a trade union. We have all that as part of our association. All the different specialties are as well part of the Israeli Medical Association. We have about 28,000 members. They are personal members, and they are divided once by their specialty and the second by the place of working. Most physicians work in the public sector. We have hospital physicians, we have ambulatory physicians, and the way the structure of Israel medical system works is that every resident in Israel is insured by law. We have a national health insurance, and it is provided actually through four, we call them HMOs or sick funds, and every resident has to belong to one of the sick funds. When he is belonged, the sick fund is responsible, gets the money by capitation from the government, and they have to provide the whole health service. And you are going to see, when I talk a little bit about the testing, you will see about the challenges that we had at the beginning by having a central, in a case of an emergency, how do we divide the responsibility between our health ministry and the central government, so to say, even that we are a small country, and the hospitals and the ambulatory setting with the health sick funds. And we think that this might have also been a challenge that we had to do together with the testing itself. So I will now share my screen with you, so you will all be able to go through it. Okay, so our first cases were identified by the end of February 2020. The cases were mainly from people coming from abroad and bringing it in, even that we knew it. Right at the beginning, we wanted to try to stop it and keep it as much as possible under control. So we had fairly early on very strict restrictions. And we had a general lockdown, which really included everything. We closed the airports. We are in a unique position because we have only one way to approach us. So we don't have a lot of open borders. So we closed everything down, and we were in different stages of a lockdown for about 2 months. Which basically helped us very much to go through the first phase and the first wave of it very well. And we were very low in our numbers, both of people who got infected and, of course, people who got seriously ill and even in deaths. But what happened was that we know today that we probably were a little bit too, I would say, arrogant with our approach, and we thought that we knew how to handle it, and then we decided to open the economy quite fast. We did that because there was a lot of controversy in Israel itself. Because of the fact that while we were in total lockdown, there was a lot of effect of the economics. We are close to a 9 million population, and after the lockdown, we had close to 1 million people out of work one way or another, and the feeling was we have to get the economy back. But then probably what happened was we did this a little bit too fast. I would like to say one more thing, that we also have a challenge because in our culture, Israelis have a lot of different sectors, but all of them together are very warm, touchy, close to each other, and therefore what is needed this time to combat actually the COVID-19 is actually problematic for us. So this is what happened. And if you look at our stats and figures today, you will see that we have dropped dramatically to have one of the highest morbidities in the world. Our death rate is still not so high compared to how many patients we actually have and infected people, but it's rising, and obviously we really have a problem. We are reaching, as of today, close to 250,000 of people who have been infected by the virus. We're not saying that they're actually sick, but at the moment we have 70,000 people that have been registered sick in one way or another. We have 1,571 deaths, which for us seems really a lot. And we are currently having around 70,000 tests per day. So because we saw that everything was rising and all our efforts in order to explain the public to take the precautions, they weren't met very well. So we had to go into second lockdown on the 18th of September. We initially said it would be for about 3 weeks, but now it seems that it's going to be much longer. And we don't know exactly when the economy or the schools are going to open. Early on, when we thought about the testing policy, the Ministry of Health was very, very restrictive about it. And what they said was at the beginning that we only want to check those that are coming from abroad or people who have been with verified patients, as you can see, or that it is clear that they have some signs of the chest infection. In early March, the feeling was that it is not a spread within the community, and therefore we can actually limit some of those testings, and we don't know exactly 100% what caused what and why they said it, but our idea was, what we thought was that there was a problem within the tests themselves. We're talking about whether we had enough devices in order to perform the test, and maybe that was some of the reason why this was more or less the policy at the time. So we actually thought that there wasn't enough equipment, and when we did get a large purchase of the equipment, we did see a change in policy. The idea for the testing is, as you know, and this is what we was said here, is first of all, we want to find the patients, we want to treat the patients, we want to prevent the spread of the virus, but we also want to try to monitor it in the whole area and try to gain some epidemiological view of it. The idea behind this was that maybe we would be able to somehow have more restrictions in some areas rather than on the whole country, and maybe we would be able to help a little bit the economy through that. The two tests that are most common in Israel is, of course, a PCR test where we identify the coronavirus, and we have a lot of debate about the serological testing. Serological testing is being done mainly by the HMOs. They want to try to see if they can understand anything out of it, so sort of whether the population was exposed to the coronavirus and how much of it. But there is a lot of controversy going on, and the idea is that they don't really know, according to that, what it is. What they did get the figures up till about a month ago, that according to what they found out was a serological, about only 2% of the population has been exposed. Obviously now the numbers have been rising, but again, there's a lot of controversy, and people are just abandoning that and more concentrating on the PCR. I would like to say another thing that you have to say about the beginning. When the virus broke out in Israel, we actually had only one laboratory that was able to perform, it was licensed, I don't know so able, but was licensed to perform the PCR test. As you will see, this has changed dramatically, but this also was something which actually hindered the capability of having a lot of tests. We had a lot of controversy where what happened was the government came and said, okay, don't understand. By testing, it is not a cure. So yes, it's important, but this is not the most important. The second phase was that towards the summer, people were saying, okay, we want to go to be tested on our own. We are willing to pay for it privately. The reason they did that was because they wanted to feel safer. They wanted to be able to, workplaces said, maybe we can test our workers and then maybe we can open it a little bit faster, and so on and so forth. And the first stage was that the government said, okay, this is a national resource. We do have a problem if people are going to try to make money off it. And then it wasn't allowed at the beginning. What happened later on was that because the idea was that some people, if they want to travel abroad, they need to show a corona test as well. So then they said there is no reason that the government should pay for that if somebody just wants to do it in order to travel abroad. And then the guidelines changed again. And they said, okay, we are allowing hospitals and private entities and even HMOs to perform this for a fee. So far, it's working okay. There is said that there's going to be a close monitoring to see whether this will affect the amount of testing that we can have in the whole country. At the moment, as I started to say, because of what happened was, and we saw it, we need many more laboratories. We have at the moment 40 laboratories across the country. We think that this is going to be enough at the moment. We can't say. At the moment, it seems that it's okay. The way it's performed is that we can have it in three different ways. You can have the HMOs, and we have the HMOs setting up separate places, sites where a person can go to his own HMO after he receives via email, via internet, or by the phone. He receives he's referred to a corona testing by his family physician. So then he can go and appear in one of the HMO's testing sites. You can also go into a drive-in, which were at some point very popular, but then it became much less. And the other thing is, if he feels too sick or he can't go out of the house, and we have our Magen David Adom, which is our Red Cross, and then we will have an ambulance service, we call it, but it's also sometimes private cars who actually volunteer to work in this, and they come to the person's house, they take the swab, and all this is transferred then to the tests, to the 40 laboratories. What we know is that you can't just go ahead and do it unless you do it for money. You need to have some guidelines, and according to the current guidelines, doctor is the one who refers you. He can obviously know, if you were exposed to a verified patient, you of course can get it. If you have symptoms, then again, the doctor will be the one who will decide whether you're going to have it or not. We know that they're usually extremely liberal in allowing the testing. As I said, at the outburst of the virus, they were much more restrictive, and the feeling was that it was due to shortage of supplies rather than different guidelines actually there. We do have even now a lot of criticism about the fact that we would like to get this to be working in a more efficient way. One of the things that we know today that we are still lacking manpower. We are lacking manpower, and in certain surges we've experienced that people had to wait for a very long time. We call it a long time because we would like to see people get the answer within less than 24 hours. And we know that sometimes now they say, okay, 36 hours. There have been even cases where people had to work for 48 hours. I want to say one more thing, just if it wasn't clear. We are talking about testing in the community setting. Within the hospitals, it is different. When you arrive to a hospital for any treatment, in many hospitals, the policy will be to admit you as a suspected coronavirus patient. You will be checked immediately. You will be isolated, and there usually they will get the answer within a couple of hours. So what I was trying to say is the general population. We also have some discussion about sometimes inaccuracies about the testing. That's been less, but we've heard something. But we've also heard that it's been sometimes hypersensitive testing. And usually we hear this within asymptomatic patients, but we still think that it's better to be careful, so we are continuing in the same policy as it was before. I just want to say one more thing. It was allowed, or it is allowed now for our services to actually monitor our phones and and you get a message if you were in the vicinity of a verified patient. And if that happens, then I have to isolate yourself, and then you can go and get a testing, or you can appeal this and speak to someone at the Minister of Health, and they will say whether in this case the vicinity and there were masks and so on, whether you have to go through the whole procedure or whether you can actually not go through the whole thing. So that is something that has been changed. One more thing that has been changed is the idea that at the beginning we also tested everybody at the end of the sickness or at the end of the isolation for those who were asymptomatic. What happened was the Ministry of Health changed its policy in the last months and said that after a certain day, which basically would be 10 days for asymptomatic patients, or 3 days after you've had symptoms and they've been and you're over them, and you consult your physician, you can automatically be released and you don't need to have another testing. So this sort of says that when I say that we have 70,000 tests today, it's tests to identify the coronavirus at the beginning, and that of course including testing at the end. Because of what I said, you have to understand that in Israel, we've had a lot of mistrust of the public. And you can see this by the fact that it is very difficult to engage the public on keeping the rules. Some of it had to do because they felt that some of the testing, as I said, wasn't done exactly with full transparency. What we also found out is that sometimes the idea to have the population to come and be tested, it makes a lot of a difference. What is the incentive or the disincentive of the testing itself? We have especially two groups of population which we have very much difficulty to impose the rules on. One is our ultra-Orthodox Jews, which part of them is that they like to pray together. They like to have big families together. They are big families, and they also have a lot of celebrations. It's very, very difficult to keep, and they live usually in very tight quarters, so it's very difficult to keep the virus from spreading. The other population that we have is some of our Arab population that, again, especially in festivities, they come together as large groups. Now, what happened was that we tried at the beginning to say we want to understand where the virus is, and according to that, we would put restrictions on those areas. This proved to be a very big disincentive in order to come and be tested, because we actually had leaders of these groups telling their population, their flock, don't get tested because we don't want to be part of the red zone and we don't want to be with restrictions. So it's very difficult for us to actually have a very coherent testing policy that will not create a situation with what we call playing with the numbers. If there's one thing that Israel is usually very good is how to go around the rules and how to be a little bit more inventive. But unfortunately, COVID-19 does not work very well with flexible rules, and it was gaming the system. So we are having a difficulty about this. We have a very big difficulty with authorities influencing the behavior of the citizens, and of course, vice versa. As you can see, so we are trying. We think that there is now a big difference already with the testing. We're having much more. But we also find out that testing in itself is not going to be enough. We know that our system in itself has been lacking, I think, as most medical systems in the world, with underfunding. And in this situation, we see everything. We're able to see everything that's happening. The lack of coordination sometimes can be a problem as well. We are trying, and we have been able to have all the different stakeholders coordinate much better. If we're talking about ambulatory and hospital stakeholders, but this takes time, and we know that in the middle it's a little bit more difficult. And our challenges, as we said, were enforcing the guidelines, which is really, really a serious concern for us. And we have already people coming along and saying, oh, this is just a regular flu we call it a flu with very good PR. And we're trying to explain that this is not. We are definitely worried what's going to be in the winter, but and we have to see. That's why we are currently in lockdown, and that is also a reason why we at least understand now in the second lockdown that it will be crucial after we get the numbers down. At the moment, we still don't have. We're still not there. How we get out of this, and we need a very good exit plan. Obviously, it's going to be slowly. Our citizens are beginning to understand that some of the way they worked and the freedoms that they had have to a little bit change because we have to accommodate to this new situation. So I think that hopefully, if we will be able to regain our citizens' trust, if our policy will be coherent, if we will be able to share with everybody, then I think share at the moment that our dilemmas, our shortcomings, and our hope for the future, then hopefully we will be able to meet our challenges a little better than what we did till now. Thank you very much.